Well, every single day we hear about AI, 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 AI. I mean, you flip on the TV, there's AI. You watch, you flipping through the internet, it's AI. You're on Twitter, there's AI. So we live in the world of AI, and who else is going to simplify the world of AI except two amazing pathologists defending the fact that AI is not going to take the pathologist's job, right? Yes.
We can hope.
All right. Well, I'm really excited to have you both on today's podcast and talking about AI and pathology. It's a topic that's really intriguing to me, and I think honestly to a lot of people. But let's start with a form of introduction, just so folks know about you. It's the first time you appear on Healthcare Unfiltered, so I'm delighted to have you on board. Sanjay, we'll start with you.
All right. My name is Sanjay Patel. I'm a associate professor of pathology and laboratory medicine at Weill Cornell in Manhattan. I'm primarily based in hematopathology here, so my work is largely in hematologic oncology, diagnostics. I also run the fellowship program and oversee a laboratory that's involved in spatial biology, where we look at tumor microenvironments and all kinds of tissue architecture retained in human and non-human tissue for translational research.
Amazing. I'm going to ask you whether you are teaching your pathology residents about AI. Greg?
Hi, my name is Greg Goldgof. I'm an assistant professor at Memorial Sloan Kettering. I direct the artificial intelligence and digital pathology for our very large HemePath service. My background is in computer science originally, and then I did MD, PhD, and residency. So I focus on developing AI tools that can be used with clinical samples such as peripheral blood smears, bone marrow aspirates, cytology samples, and associated clinical data.
Sanjay, let me start with you just a little bit, and welcome both of you to the show. But I just want to start by, like, when did AI become mainstream? I can't. There's always time where you can remember an event that led to something. I don't recall the time where AI became how big it is right now. Is there such a thing?
My perception is that AI became mainstream, I wouldn't say overnight, but very quickly, it seemed like. And probably in the field of pathology, that's kind of aligns with when a lot of what we work with became digitized. So we had a digital version of the material that we were using for our routine work. And I think probably around the country and around the world, institutions have worked at different paces to capitalize on that digitized material and try to use it both for potential clinical use, but also for just research and academic kind of inquiry.
But like, to me, the digitized pieces, Greg, is just simply to make it easier in tumor board to present something like telehealth. You can show other people. Like, I never thought of the digitized images as AI.
Yeah, I mean, to have AI, you need to have digitized images. Otherwise, they're just glass slides sitting somewhere. So I think that when the digital pathology was being pushed, it was for these other reasons. A lot of convenience and allowing collaboration and faster turnaround. But once the images are data, it really makes AI possible. I think the first approvals of digital pathology scanners coincided around the time of the growth of AI's capabilities in image analysis. But I think that AI sort of exploded on the scene once these LLMs came out that everyone can use to help with their various tasks. So now everyone is aware of the power of AIs, but it's been quite powerful for image analysis for a bit of time now.
Tell us a little bit more what you mean by when the LLMs came on board. Can you expand on that a little bit?
Well, deep neural networks, maybe a decade ago, made possible a type of image classification tasks that were magic beforehand. But this is not something humans typically need help with or would interact with on a daily basis. LLMs, on the other hand, are so useful for many, many tasks that humans use. So I don't know if you use it, but many people I know on a daily basis have replaced Google search and many other tasks with LLMs. So they can see every day how the LLMs are beneficial and how they are advancing. We use them to assist with programming. We use them to assist with automating different tasks. So I think that has made people really recognize the power of AI, but there were other things under the surface that were less obvious, such as image analysis capabilities.
Sanjay, for a listener who is not who's not really familiar with this, can you give me a use case where you, as Sanjay, have used LLM in your daily activities? Like, when do you actually go and use that? Have you used it today, yesterday?
I don't know that I'm in the camp of Greg's friends that that do, or maybe that I do without being so cognizant of it. So I defer to Greg a little bit on good examples of where maybe many people are using LLMs in their kind of routine daily life. I think that I mean, at least in clinical work, I mean, some of these things are kind of starting to enter our minds and how we might utilize them as part of our routine work. But I don't, at least where I practice, they're not part of the fold just yet, although we're trying to kind of ride the wave and be part of that activity and not fall behind, because that's really where things are moving very quickly.
Greg, can you give me a use case to Sanjay's point? Like, when did you use it yesterday? And which
I mean, I've used it multiple times.
Which LLM?
Well, okay, so this is not for clinical purposes, although they're rapidly rolling out clinical LLMs that you can use within your institution with clinical notes. You can use them to summarize notes, to extract data for you. We're using them. We're trying to develop tools at MSK to help us standardize and automate diagnoses that are for pathology reports, which are often non-structured. In my personal daily use, I use it almost constantly. They now have LLMs that work in the background as you're programming, and you'll start typing in some code and it will suggest the next line for it, or you could even ask the LLM a question. It'll say, well, how can you please write me a function that will do this? And it will do that for you. So it makes programming faster. And then in terms of if you're researching something for your own education or thinking about different perspectives for writing a paper or making a presentation, it's a very useful tool. The other day I was using it to give me estimates on how Medicare prices reimbursements for specific tests. It really is just an amazing tool. It's a lot faster than using anything that you would have Googled in the past. You could probably replace with LLM at this point.
So these are open sources, right? Like a ChatGPT type of thing?
ChatGPT is not open source, but it is available to everybody.
Well, right. I mean, like, it's anybody can use it.
Yes.
But is there a concern? You can't really use that for your daily clinical work because this is like privacy issues.
Yeah, so I mean, this might be off topic of the conversation of pathology, but I do know that several hospitals, they basically have contracted with LLMs like ChatGPT to have a HIPAA compliant instance for their hospital. Another approach you can take that we're using is there are open source language models such as Llama that's made by Meta, and you can download the entire model if you have the right size computer and run it locally, in which case there are no concerns about patient privacy. So there's a lot of opportunities. I think you'll be seeing it integrated into, I mean, it wouldn't surprise me if it's integrated into things like Epic pretty soon. I mean, the types of tasks that you would ask a resident to do for you, such as look up this patient's past notes and see, have they been treated before? What's their past medical history? Summarize and write for me, HPI, it can all be done in an automated way.
So Sanjay, to the simple mind, I always think that for pathology, if we go back to pathology, like, I'm assuming, and correct me if I'm wrong, I'm assuming that you guys would like to have AI to help you either in diagnosing things that you may have missed, possibly, or in I don't know, expediting your workflow, I guess. Like I'm trying just to think, where would you use it? I mean, you're experienced hematopathologist. I guess, are there scenarios where you are not sure of the diagnosis and AI could help you? Are there scenarios where it could have taken you 5 days to render a report and with AI you render it in 2 days? Like I'm trying to bring down real life examples where a pathologist would need AI.
Yeah, I mean, I think so. To Greg's point, I mean, one aspect of it for sure can be expedited synthesis of the reports that we prepare, where we document case findings and come up with a final diagnosis and report all of that. I mean, that's a largely manual and cumbersome task. Requires a lot of data integration. It's a lot of writing or dictating, generally speaking, depending on where you practice. So that facet of the work could probably largely be expedited by AI-based methodologies. And then on the diagnostic side, I mean, we are now tasked with kind of analyzing, integrating an ever-increasing amount of complex data. So to have some support system to do that, not miss nuances, or maybe help us screen and highlight things that we might have otherwise missed, because we are, after all, human beings. And at the end of a day, you've looked through 30 cases, maybe the 30th case, you're a little weary and be not as, on the ball. So having, basically an ancillary kind of support structure that will help you identify those things. I mean, of course, at the end of the day, I think the judgment component, as with all other areas of medicine, will fall, as far as I'm hoping and concerned, on still the human being to kind of piece all those things together and make a determination in the context that takes into account more than just pieces of data. But all those upstream components that are often just time consuming and involve a lot of data parsing and data analysis, I think could be largely supported by these AI tools.
But how do we get the AI to get to that level? Do we need to train? Like how do you? I'm just trying to understand, how do we get to a point where the machine is able to help you?
So I'll throw it back to Greg in a minute, but when it comes to hematopathology, I mean, one of our bread and butter exercises is smear review. I mean, in a lot of different contexts, whether that's peripheral blood smear or bone marrow aspirate smear. I mean, we spend, I'd say in our practice and in most practices, at least 2 to 3 pairs of eyes are almost looking at every single smear. So if you think about aggregate amount of time spent by a human being to execute that task, I mean, that's done so that we, of course, don't miss something. We have a technologist review a smear. I have a fellow or a resident review a smear. I review a smear. So that obviously helps in the current format to not miss things and to have enough kind of comprehensiveness of review. But AI already, Greg can probably comment on tools that are now he's developing, that others have developed, and that are available or becoming available to do that screening and kind of essentially recapitulate what the technologist and or the trainee are doing without the time spent, right? So I think that is an obvious and tremendous benefit to our workflow, and largely would minimize errors and increase inter-observer or diminish inter-observer variability, increase reproducibility. It has a lot of kind of intangible benefits.
So how
Yeah,
long
I
does
mean,
it bring? Yeah, go ahead, Greg.
well, I'll say it. I'm not worried about the pathologists being replaced, because the pathologists constantly being asked to integrate more and more diagnostic modalities to make the correct diagnosis for patients. I think there's a real opportunity to improve patient outcomes. I can take it back to peripheral blood smears. So peripheral blood smears are the second most commonly ordered test in the US. There are 500 million of them being produced annually. And this is patient data that could have quite useful information in it. And in spite of that fact, for patients with heme malignancies, it often takes a very long time for them to get the diagnosis. The symptoms are nonspecific, and they may be going to their primary care doctor, they may be going to the wrong provider. And as a result, however, if they'd had a hematopathologist glance at their peripheral blood smear, they could have identified very quickly that there's something unusual. And that's not the be-all end-all. Then we would order flow. Maybe you would see a hematologist. But we have a real opportunity to develop universal screening tools that will help patients get to the right treatment more quickly. And at the end of the day, it will be hematopathologists or pathologists who can integrate all these modalities. We have flow cytometry, we have genomics, we have all these different things that we need to know, especially with the number of drugs increasing. But how do you get, but it's simply not scalable to the amount of patients that we could be screening and the frequency with which we'd want to be screening if you want to pick up processes that occur over, a 6-month period.
Right. But to get to, I guess, take me back a couple of steps before. Like, in order for you to have the machine help you in the analysis, you have to train the machine before. So I guess, I mean, because there's like, my gosh, I mean, there's like, 60 lymphoma types. There's like, 30 leukemia. There's so many of these types. I'm just specifically focused on hematopathology only because I did lymphoma, but I mean, obviously there's so many other things. So it's hard for me to imagine how you're going to train the machine for how many samples of NK lymphoma you need to show a computer to become comfortable that they're going to identify this, or APL, or like, that's where I'm struggling with, because and maybe I'm wrong, I'm imagining you have to train it for every subset of every leukemia, every lymphoma, every MPN, every MDS, no? Or am I off?
I think you're imagining a world in which the AI is replacing the pathologists, which I don't think will happen, especially just based on image analysis. There's not enough information there. So you have to think of what the AI can do for you at different stages along the journey for the patient. So at MSK, we have humongous cohorts of every cancer you could possibly imagine. And we are going to be using those cohorts to train AIs to help us at different stages. But the first stage might just be, does the patient have a high risk for malignancy? Okay. Is this a normal blood smear or not? And for that, you really only need to know which of your patients have normal and which of them are not. We have large cohorts of patients with solid tumors versus not heme tumors. Then you may want to ask some more refined questions. Questions such as differentiating between different types of mature B-cell neoplasms from circulating lymphocytes, probably will not be perfectly answerable by looking at the image of the peripheral blood smear. But this is why we have flow cytometry. The goal is not to just from an image replace all the additional testing, but it really allows you, we could really be screening all of our patients. Like, let me give you another concrete example. Let's say you have a patient with a mature B-cell neoplasm. They may have some sort of symptoms that are non-specific. They go to their doctor saying, I have fevers or something, and they have a CBC performed. The CBC is normal. If it's normal, it will not be reflexed to a smear. It will not be seen by a lab technician. It will not be seen by a pathologist. However, it's possible, let's say the patient has CLL, that 50% of their lymphocytes have already been replaced with abnormal lymphocytes. If a pathologist had looked at that smear, they would be able to tell. And so we can train an AI to replicate that and be the screen. And we can even say, for humans, it can become difficult if the percentage becomes low and you have mixing of like a clonal population and non-clonal population. But the AI might be able to detect a very low level of circulating CLL that a human would not be able to tell with their eyes. And of course, the follow-up will be flow cytometry or go see a hematologist. It's not meant to be one test to solve all problems.
Very, very helpful. Thank you. Sanjay, in the world of biomarkers and, genomics and NGS and all of these things, are we able to use imaging and pathology to predict potentially a biomarker aberration, overexpression of a particular oncogene or things like that, or protein or something like that? are we there yet, or is this subject of research, or can you apply AI and algorithms into pathology images to predict the molecular underpinning of what you're seeing?
Yeah, I mean, I think there's a lot of interest in trying to do that in the last several years. There have been a few, at least a few published studies that I've come across. The focus has largely been on trying to correlate something in imaging data, maybe a smear image or something along those lines, with known genetic findings. I think a great example is an area of leukemia that I'm personally very interested in, which is NPM1 mutated acute myeloid leukemia, known to have, not in all cases, but in many, blast morphology that's called cup-like blasts. I think that's a great use case example that lends itself to exactly what Greg was just describing, is training an AI to recognize these types of blasts as a predictor of an underlying NPM1 and or FLT3 mutation. Both of those are kind of commonly encountered in that morphologic setting. I don't know that there's a ton of examples that can be applied in this way. I think there are definitely some. You can think of salmon-colored granules in, 821 leukemia. I mean, there are probably examples like this that are a bit easier to use for this kind of a exercise, but I think there's a lot of interest in doing that. And I was going to add one thing. We think that, maybe in the United States, there are certainly a lot of uses for AI, like Greg has described, but there's worldwide application for this. There are so many underserved areas of the world where, forget about flow cytometry or, and certainly not molecular diagnostics. So in those places, to be able to offer even to recapitulate what a hematopathologist would say from a smear alone is such an asset, because they don't have hematopathologists, or maybe they have one for their entire country. Or maybe they have a pathologist who's not specialized in hematopathology. So, I think that we have to think broadly about what the benefits are. They're not restricted to our country alone.
Yeah, no, totally. I come from low middle income country, and I was thinking about, you're right. Most pathologists are general pathologists, and sometimes they develop an interest in hematopathology, but they don't necessarily have a formal training in hematopathology. And I think there's a lot of value there. Sanjay, you mentioned something about spatial pathology. Can you tell us a little bit about this? And is this related to AI or a completely separate field?
I think I guess I can think of it like an input to AI, the same as the smears we're kind of describing, maybe just a different kind of input where similar analytical approaches can be applied and are arguably necessary to make the most out of these types of data. So what I'm describing is you can think of it as like flow cytometry on a slide. So instead of having a single cell suspension from a sample where you don't know any of the architectural features of that specimen or that tissue, here the tissue architecture is retained. So not just the morphologic features of the slide, which you'd get from an H&E or a smear. Smear, obviously not an architecturally retained kind of sample, but you'd have the cell positions retained. You'd have the macroscopic and microscopic architectural features of that tissue retained, but in that context, you can phenotype the cells. And so you can say, well, this is a B cell residing next to a T cell, or this is a T cell residing next to a macrophage, or these immune cells are close to or away from a solid tumor malignancy. And I think we're probably, the field is not nascent by any means, but I think we've probably barely scraped the surface about what we will be able to eventually uncover by using these kinds of approaches. And a lot of that has to do with how the image data has been analyzed. So I'll give you an example. When I was finishing my kind of research training, it was a point and click approach to doing labeling of cells in an intact image of a tissue, an image of intact tissue. So we were performing the phenotyping. I could say this is a cell X, Y, or Z, and this is its position. But we didn't go too far beyond that. There was nothing really super automated or particularly sophisticated about the process beyond that point. But even in my own work since then, we've come a long way in terms of being able to use more sophisticated, I'd say, AI-based approaches to ask a lot of spatial questions about tissue architecture. And these are things that the human eye, I don't think, can appreciate at all. Our gold standard ways to analyze, for example, lymph node tissue or bone marrow tissue our microscopy and human and visualization of what we can see on a slide. But there's so much more we can extract about microscopic architecture, and I think that we have a lot more to learn about what that means for disease, response to therapy, and so on and so forth. You name it.
I like how you described it's one of the inputs. I think that's actually pretty interesting because it's just one of the variables that are very important.
Right.
Greg, are there areas within pathology where AI is more important? Obviously, I'm talking to a hematopathologist, but do you see variations? Otherwise, you guys have utilization for AI more than a breast pathologist or a GU pathologist, or it's really applicable to all kinds?
I think it will be applicable everywhere. I mean, there is some penetration in certain high volume situations. So there is some AI already being used in the lab. We have Celavision does a differential based on image analysis of peripheral blood. There are tools for assisting with Pap smear analysis, I believe. But I think it is valuable in all fields of pathology and diagnostics more generally. In the clinical laboratory, I think there's going to be tremendous information you can draw from patients' labs. And I also think, people are looking into extracting data from the patient's chart and combining it with laboratory data and other forms of data to help physicians not miss things that are starting to brew. So, I think in some ways, tissue pathology has been the focus of a lot of the research because they are more likely to be scanned. There are more scanners available for that, and it's more common to scan. But the liquid specimens, like the heme smears and the cytology specimens, are high volume and are going to be very important.
Yeah.
So no, yeah.
So going back to Sanjay just a little bit, you mentioned you're doing some stuff in the lab, translational lab, or AI is integrated into some of the research that you are working, or this is completely separate outside of AI?
Yeah, I think that the current reality is that we prepare images like the ones I've described. If you imagine flow cytometry on a slide digitized as an image, in a variety of contexts, we do this both in heme and a lot of non-heme kind of areas. It's largely skewed towards research application at this time. But when you have that image, I mean, what you can do with it can span from something very simple, like what I described I was doing at the end of my research training, to more sophisticated things like what Greg is doing now as a primary kind of focus of research. So it really depends on what the goals are with that particular type of study, how far you want to go and what kind of tools you want to apply. But I have now become very interested in applying AI-based image analytics because I just see how much more fruitful they are. But with that comes a lot of challenges in a way. You need people with expertise. You need people with significant bandwidth. And so that's, you kind of have to pick and choose where you want to focus. I mentioned that I'm kind of involved in the training program. One thing I've noticed, at least in pathology training, is that we have, and I don't know if this is just true across the board in medicine, maybe it is, but we have more and more people that have some amount of computer science background coming through training. And that wasn't true, when I was going through residency, even, 10 years ago. So I think that this is almost a requirement for us to be able to create a critical mass of people that both speak the language and or can execute the tasks, and maybe some combination of both.
Actually, that was my second question to you, and you beat me to it, which is as a director of the training program, I mean, do you integrate AI as part of the curriculum? Because, I mean, and how do you do that? I mean, is this part of the training where they have to read certain things, do certain courses, or is this more of an elective type of thing? If you really want to do it, you could do it.
So I mean, in our, so I don't direct the residency program, but I do direct the Heme Path Fellowship program. So for the residency program, of which I'm also, actively involved in that kind of structure. But for the residents, I think that because they have 4 full years to focus, and to be here and go through the training, we are starting to increase the amount of exposure that we have to data science, big data, AI-based kind of applications, especially within the field of pathology, not necessarily to train individuals to be data scientists, but to help them get comfortable with the lexicon. Because I think that if you emerge from a training program in the year 2024 and you don't have at least some concept of the language around AI as it might apply to pathology, I think you're maybe going to be in trouble unless you're a good self-learner and can figure it out from there at that point forward. The Heme Pathology program is a 1-year program, generally speaking, maybe 2 years in some cases. And there's so much heme path to know. We don't really have the luxury to incorporate much kind of AI or data science focused training. But I'm always trying to pass some of this literature on to the students that I work with, because I just recognize that it's such a fast moving train. You have to get on sooner rather than later. Otherwise, it's going to be challenging, I think, down the road.
But there's so much like noise, and sometimes it's very difficult for the non-experts out there to separate signal from noise. So what sources, how do you know, Greg, if something is really real versus what they call in the world of AI hallucination, or like, and also sources actually for folks who are interested, where do they even go? I mean, you can Google AI sources and you'll just go crazy and dizzy, which I did that exercise in preparation for the show. I mean, there's so much out there. I don't even know where to go.
Yeah, I'll touch on that. I also want to touch on the training aspect, if I forget. Telling what is real from what is not real is extremely difficult and basically impossible, even if you are an expert. Just because something is published in a major journal does not mean that it is real. And I would especially caution, if something sounds too good to be true, it's probably even more not real. Because it's very easy, if you have a poorly designed AI experiment, even without malice, to have the AI basically learn confounders or little issues with your data that give you extremely high performance. So if someone tells you that they can, with 99% accuracy, tell the difference between, a lymphocyte that is follicular lymphoma or mantle cell lymphoma that's circulating, or something that sounds preposterous to you, it probably is. So I would exercise extreme caution. You're a pathologist, so you have the ability to do a sniff test, right? You know what something should look like and what the right answer is. So if you haven't seen it tested on something that you know, I would not trust it. I would take all literature with a grain of salt, and I wouldn't purchase any tools without testing them yourself.
By the way, how much your background in computer science led you to decide you want to do pathology specifically?
100% it was involved. I mean, when I finished residency, I was convinced that there was a lack of, let me just say that my medical experience didn't gel with my sort of engineering way of how things should work. There is a lack of consistency. There's a lack of efficiency. I felt like we were not doing what's best for our patients. And so I said, this is maybe not a good personality match, running around the wards like a chicken. Like, to me, it wasn't the right fit. So I said, I'm going to do something related to computer science. Where can I do this? And so that's how I chose to go into pathology. And this was right around the time digital pathology started to become a thing. And I was very interested in image analysis. But I want to talk about training just briefly. I believe I'm associate director of our informatics fellowship at MSK. I may or may not be. I think I am. But so we just started a new fellowship, and in informatics. So if there are any pathologists out there who want training that is very focused on AI, and I would recommend contacting me. We're looking to recruit fellows. I have to say, if you have some programming background and you are in residency training, this is like pure gold. And hopefully you're in a place that allows you to build on those tools and start exploring them, because the combination, developing AI algorithms is extremely difficult if you don't understand what you're developing for. So the combination of some of the medical knowledge, the real expertise, and some programming background can really help you. And with tools that make programming easier, like LLMs, ChatGPT, which we discussed earlier, you can really move quickly. I have to say, like, we have right now as our inaugural fellow was a person who was a cytology fellow last year with a very strong background in programming. And he has been guns blazing for 2 years, for a year now, and he's working on evaluating LLMs to parse our path reports and building out a pipeline for establishing a foundational model for cytology samples. So there's tremendous opportunities for those who have some programming experience. If you do not have programming experience and you're interested, I'd really recommend that you just try. It's never been easier. Try to learn some Python. It doesn't need to be for research or for medical application. Just go online. You can even ask ChatGPT, how do I learn to program? And it will tell you. And then you can really build from there, because these are basic building block skills. It's how it's like, knowing how to read unlocks all books for you. And knowing how to do some basic programming in a language like Python can open all the sorts of fields of computer science to you. It's not necessary to have a computer science degree. And a lot of people you can start with your own little projects, make a little website, automate some of your emails. You don't need to start big, but I would say start small. It's never too late, and it's a useful skill. And even if you don't use it, it will give you some nice fun.
Like fascinating. I mean, seems like I'm going to try to do that. Let me just go back a little bit, just in the last segment, just thinking through. I'm trying to distill the use of AI in medicine. Let's take away the pathology hat specifically, right? I mean, so one, I'm thinking, okay, could be predicting something. Like if I don't know, throw at you 1,000 medical records, maybe you could predict for me who is going to be at higher risk of X, Y, and Z. I mean, that's like predicting something, I guess. Maybe prognostic. Maybe I can show you whatever, and you can give me algorithms of prognosis, right? I mean, that's where I'm thinking this applies. I mean, at the end of the day, right? I mean,
I could give you a concrete example of a research project we have in our lab that exactly fits to this. So when I was training in residency, they would always tell me to look at these peripheral blood smears and look for schistocytes. Because if you see schistocytes, your patient might have microangiopathic hemolytic anemia, and you need to call the team because you could save a life. And actually, a different resident did this at UCSF, not me, and was thanked by a neurosurgery head of neurosurgery for the phone call that he made. Now, this was quite nerve-wracking and also seemed wildly inefficient to me, because most peripheral blood smears are not going to be reviewed by the resident, let alone a pathologist. This is the type of thing that could easily be missed. So I decided to start a project to ask the question, can we predict mortality risk from peripheral blood smear image? Okay. And the theory was there are some things you might see there that are associated with microangiopathic hemolytic anemia, or DIC. We use a combination approach of AI that looks at the red blood cells and the white blood cells. And we had a very large cohort of patients. Most patients who are about to die have received a peripheral blood smear within 24 hours. And I have to say, I mean, I can't go into too much detail because we're writing up the manuscript, but it's already shown as very effective within 24 hours of predicting mortality. It reveals a signature because it can tell you what are the elements of the smear that it's using to make this analysis. And one of the elements, one out of at least 5, is the presence of schistocytes. But it created this interesting fingerprint that it makes perfect sense once you've seen it, but would not have been what I predicted from the beginning. And if you only as a pathologist had a couple of those things, you might say, oh, this is associated with this heme malignancy, or this. Each individual one does not create a signature that would really predict death, but having all 5 of them is highly predictive. So we're repeating this experiment to see how far back we can pull it out, and also to evaluate how useful it is in different situations. So how many of these patients are already in the ICU? How many of them are not in the ICU? And we can also give some information about the underlying what's happening. I mean, right now, if you think about how you would diagnose DIC and follow it, it's quite complicated and I would say not efficient. We have all these metrics for evaluating which patients are about to crash. We have these sepsis criteria, SIRS, Q-SOFA. We have people worrying about HLH in various ways. And a lot of these questions you can get by using AI to sort of multifactorially predict something. And this is, we were able to with the images, but just imagine how much the performance is going to increase once we add vitals and blood chemistry if it's available. It's going to be, I think, highly predictive.
Well, if Sanjay reviews the paper, I think he may accept it. We'll see.
I hope so.
Sanjay,
One can hope.
Sanjay, with my last question, maybe to both of you, but Sanjay specifically, like any new tool or new toy in life, there are always pitfalls or shortcomings or certain risks or things to worry about. It can't be all nice and dandy. I mean, nothing in the world is always amazingly great and there are no downsides. What should people in general and physicians in particular watch for when we are dealing with AI? I mean, let's face it, we're going to use AI moving forward in the future. I mean, whether we like it or not, it's going to be an integral part of our medical life to various degrees. Maybe Greg uses it every day. I use it once a week. You use it twice a week. It does, but it's there to stay. What should we watch for?
So one of the things that worries me, and I think it kind of maybe answers your question in some way, is I'm worried about a move towards loss of critical thinking when AI becomes more ubiquitous. And that may happen subconsciously, not intentionally, but I do worry that it'll happen, and it'll happen to more and more people. I mean, right now, I think for people like Greg, and I'd like to think like myself, AI applications and tools and things we're talking about, I still approach with a healthy dose of skepticism, or at least I try to be discerning about what information I'm being provided and try to reconcile that with knowledge that I already have or judgment that I already feel about something. But I worry about a time when you stop doing that as much, and therefore you're just trusting the information that's being fed to you. And I think that that's probably one thing to be mindful of. And I think that mitigating against that involves learning about AI, about how these tools are developed maybe a little bit, or what information is actually being produced and how it's being produced, so that you can guard yourself against these pitfalls. But I think it's those who maybe skirt past this phase of time and then start to just adopt AI blindly, who maybe aren't as interested in what's under the hood, and they may be the most liable to fall in these traps, right? I mean, if you don't know how it works or you don't care, then you don't really, you're not really in a position to question the data or question the answers that are being given to you.
So, Greg, in every podcast, there's always a quote that I end my podcast with a quote. Like after you guys sign off, I usually do an intro and all of these things. I'm going to read to you a quote I'm going to put for this episode, which is by Stephen Hawking. Success in creating AI would be the biggest event in human history. Unfortunately, it might also be the last, unless we learn how to avoid the risks. What do you think?
I think it's a beautiful quote. It may be, I think it's always worth anything that's very powerful, dealing with caution. I would say my attitude towards AI, here's a way you could think about it as a clinical attending. Imagine you're an attending and you're rounding on the ward, and a person shows up who is now a member of your team, but you have no idea whether that person is a high school intern, a medical student, a resident, or a subspecialist who's going to help you. And so you kind of have to suss out that for yourself. And I think your level of, once you have interacted with it, you can kind of learn how much you can trust it. So I think that as long as you think of this in different applications, so like for an LLM, you can think of it as an extra resident that you have around. So you might be saying, you know, I think this patient has these symptoms. I think it's this, 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 or this. You could put it into an LLM to ask, are there any zebras I've forgotten? And you may find that it can provide them, but you are the actual expert who can determine whether those are useful or not. Or you may want to ask, what are tests available for this differential diagnosis? You know, it's hard to stay abreast of all the new tests that are coming out constantly. So it can be useful for that sort of thing. But, you know, these LLMs and many AIs, they're not perfect. So they really rely on you as the expert to direct them. You should think of them as a resident or an intern. But one that you can have an infinite number of and that have access to all data.
I think I need to do a podcast specifically focused on LLMs because there are a lot of these LLMs out there, frankly. And I think for the average consumer, whether in the medical field, outside the medical field, they probably don't understand the nuances between various LLMs. And if one is better than the other, and when you get a new LLM, how does it differ than the older LLM? And things of that nature. I feel there's a lot of confusion about this, to be honest, just by talking to random people. Obviously, for you guys, it's different. But if you talk a random person, I'm not sure they have that well of expertise.
I definitely think it would interest your audience.
Yeah. Final thoughts. Did I forget asking you anything that folks need to be aware of and be familiar with? Anything I may have forgotten? I mean, obviously, this is very broad strokes about general topic. There's a lot of details, but hopefully we teased listeners and viewers enough that they really pay attention to future podcasts because I'm going to do several of these on AI. But any final thoughts from both of you?
I mean, I guess I'll say that and we kind of touched on this a little bit during this session, but you know, I think the whole topic of AI is something that may be hard on the surface to find an access point. But once you do, I think you can start to get a little comfortable with the concepts and the language, and then it becomes easier and easier, almost like anything else. So I think I can imagine for many people it feels daunting to even get started. Where do you begin? I mean, how do you get for yourself familiarized? But once you do that, I think it's super exciting, and you can probably envision a lot of applications in your personal life and certainly in medicine if you're a medical practitioner. Where it can really be involved, you can really be involved in what you do.
Well, this is a book I'm reading right now, Artificial Intelligence for Everyone. See, I'm trying. All right, Greg, your final thoughts.
Oh, I just wanted to agree with Sanjay that at the end of the day, there are many talented computer scientists, engineers, data scientists who can develop AI models, but they really do not have the background to know what are the right questions to be asking. And so, but in order to, I think, work with them or understand them, it behooves us to have a little bit of knowledge. So I thoroughly encourage physicians to start playing with some of these tools and not just and sort of be part of the wave. You know, when I have data scientists working for me or computer scientists, and they have some project to work on, like, is this a blast, not a blast? I say, you know, you don't need to understand all of medicine, but you need to know what a blast is or not a blast in order to like have some idea about whether you're making progress here. And similarly, I think as physicians, we're really in the driver's seat about what is important clinically, but I think we need to know the basics of AI so that we can think about where those applications would really benefit our patients.
Amazing. I can't thank you enough, guys. This is really extremely helpful and wonderful. So I really appreciate you joining me and being part of this podcast and coming on Healthcare Unfiltered.